Hello, everyone. My name is Chloe. I am with the Tascop Global Consulting Group. It is my pleasure to start off this session today titled Improving Health Outcomes in Inherited Blood Disorders. Now it's my pleasure to introduce our moderator for today, Dr. Leon Chololo. I'm going to provide a quick introduction. He is a professor of pediatrics and hematology at the Official University of apologies. You saved you saved me on that. Thank you. In the DRC and a visitor teacher at the University of Kinshasa at the University of I should have double checked these Lubumbashi. Thank you. Dr. Chololo is the director of the Institute of Research and Biomedical One Health associated to the CEFA Moncole in Kinshasa, DRC. He has dedicated most of his research activities to sickle cell disease. He conducted an NBS pilot study in DRC and a phase 2 study of the use of hydroxyurea in Africa. Dr. Chololo is also a co-chair in the Sickle in Africa Consortium, expert consultant in the WHO, and president and co-founder of the REDAC, a network of sickle cell disease research in Central Africa. He is a member of, my French isn't good, Académie de Médecine de France and the Académie de Police. Oh my goodness. The sciences, lots of amazing accolades. I will practice my French, I promise. Please help me welcome Dr. Chololo.
Thank you very much. Are you hearing me?
Yes, we are.
Thank you very much. Yes. I tried to put on my video. I think it's okay now. Thank you very much. It's a real pleasure for me to take part to this first day of the GANSID meeting, a very exciting meeting that will concern the blood disorders. And today, on the first day, we'll have 3 talks. The first one will be made by Dr. Adetola Kassim. He will discuss the indications for a curative therapy for sickle cell disease. And after we'll follow the next presentation will be made by Dr. Maureen Achebe, who will talk us about gene therapy, if it's available and in low and middle countries. And the last one will be Dr. Jason Softman, who will discuss about the treatment options changing the approach to bleeding disorders. So as we said, during the meeting, we have just 12 minutes for presentation. And Apple will get some questions in the chat, and the moderator will also put some questions to the lectures. So I will invite now the first presentation to start. Over to you.
Yeah, good morning. Thanks, Dr. Chololo. Are they going to put up my slides, or do I have to do it myself?
That's up to you. Would you like us to do it?
Oh, I can do it. I just I don't know if I have the rights for the video.
You do.
All right. So or is it easier for you to put it up?
I can absolutely do that.
Yeah.
And you can click, you can just say next whenever you want me to change it.
Yeah, so next. Yeah, so Good morning, ladies and gentlemen. My topic was transplant in hematologic inherited disorders, but due to the time constraints, I think we could focus on sickle cell disease, you know, as an illustration of how to, go about with curative therapy for inherited blood disorders. The dilemma in sickle cell disease is it causes progressive infarct recurrence in children with both overt and silent strokes, despite best medical management strategies, i.e. blood transfusion, and also early deaths in adults. Successful bone marrow transplant may be an alternative to lifelong blood transfusion therapy for children with pre-existing cerebral infarcts and medical management of sickle cell disease in adults with a high mortality rate. Next slide. Since this is a global conference, you can see the global incidence of sickle cell disease, and with sub-Saharan Africa being most impacted with over 5 million people. India has more than 1 million, the Middle East as well as North America about the same, and less than 100,000 in Latin America. Europe only has only 40,000 recorded. Next slide. Adults with sickle cell disease have a shortened lifespan. Despite progress in the management with prevention of pneumococcal infections and early childhood death, hydroxyurea standard care, and early detection of cerebral vasculopathy and stroke prevention by TCD, the median survival for patients with hemoglobin SS is 48 years, with no change in the last 25 years. Looking at the diagram below. Next slide. And the issue is chronic organ damage. The heart, lung, and kidney complications account for over 50% of identifiable causes of death in sickle cell disease. Cardiovascular disease causes 26% of deaths. Elevated TR jet velocity consistently predicts early mortality, about 10 times increased mortality risk. FEV 1% predicted of less than 70%, present in 11% of children and 32% of adults, and every 1% decrease in FEV 1% causes a 2% increase in risk of death. Patients with decreased eGFR or estimated glomerular filtration rate observed in 19% of adults is associated with a threefold greater risk for death. Next slide. In our Vanderbilt cohort in the United States, survival for adults with sickle cell disease is impacted based on their degree of multi-organ impairment. Shruti in our group looked at our population over the years, and she found out that those with one or less organ impairment, their median time to death was 14 years. When they have more than one organ impairment, their median time to death is about half, about 7.8 years. Next slide. Question then is, what therapy can impact the most debilitating complication in children and improve survival in adults with progressive organ dysfunction? So the ideal curative therapy profile should offer protection from sickle-related complications, both clinical and subclinical, acceptable toxicity profile in the short term and long term, accessible and available to most patients, and safe for children and adults. Next slide. Allogeneic stem cell transplant appears to meet all criteria for curative therapy. Donors can be from HLA-MAC sibling donor, a match-unrelated donor, an HLA haploidentical family donor. Traditionally, patients receive myeloablative chemotherapy, but in recent years, non-myeloablative therapy is preferred. And if you look at the schema to your left, it clearly shows that if you replace the diseased red cells, you can clearly abrogate all the other downstream effect of sickling, hemolysis, adhesive interactions, inflammatory stimuli, or the procoagulant state. Next slide. This is well known to everyone that for children with sickle cell disease, excellent outcomes with MAC sibling donor allogeneic transplant for over 3 decades. The 5-year event-free survival is over 90%, as well as the overall survival. Event-free survival were found to be lower with increase in age or transplantation, and small donor pool for children and adults with sickle cell disease, with less than 10% being available. And this prompted the non-myeloablative transplant being preferred for adults with sickle cell disease. Next slide. We obviously participated in all the therapy, curative therapy for sickle cell disease in Vanderbilt, and we created an automated contemporaneous cohort in children with sickle cell anemia to predict survival after disease-modifying therapy. And we were able to identify 419 individuals. Median age was 10.2 years, median follow-up about 7.4 years. And we looked at their survival over like a decade. As you can see, there were 47 deaths. Interestingly, even though the numbers are small, the 22 patients who were transplanted are all still alive. Among the patients taking hydroxyurea, we've had a diminution in survival. It was worse for those on chronic transfusion therapy, and those on no treatment were actually the worst off because we've kind of lost patients based on that. Next slide. So how do we address the unmet needs for allotransplant in children and adults with sickle cell disease? Children with strokes with no matched sibling donor, myeloablative therapy deemed too toxic for most adults because of pre-existing heart, lung, and kidney disease. 60% at least one major organ dysfunction, and 25% have 2 or 3 organ dysfunction, and the lack of awareness of benefits of transplants. So we need less toxicity and alternative donors. Next slide. Unfortunately, the outcomes using other alternative donor transplant for sickle cell disease have not been great. If we go back to the BMT-CTN study looking at a reduced intensity in 30 children, the outcome was not great because there were the incidence of significant chronic graft-versus-host disease was about 62%, and there was 34% incidence of PRES and 7 GVHD-related deaths. An attempt was made to use cord blood, and as you can see, it had to be stopped prematurely because 5 out of 8 patients had graft failure. Next slide. So this, of course, galvanized the use of HLA matching in haplotransplant. And a haplotransplant is a primary relative, your immediate family members, biological parents and children who will share a one HLA haplotype 50% of the time. Secondary relatives, grandparents, grandchildren, aunts, uncles, nieces, and nephews. They give the same results as first-degree relatives. Third-degree relatives are your first cousin. They have a 25% chance for being a haplo match. Most patients will have haplo when extending the search beyond family members. Next slide. The initial results using a haploidentical bone marrow transplant from the Hopkins group was not optimal. They had a 43% graft failure rate. 14% had mixed donor recipient chimeras. There was no acute or chronic GVHD, however, and there was no mortality. Next slide. So this prompted us to develop a Vanderbilt Global Haploidentical Transplant Consortium, and our results for over a decade just got published in Blood this year, and it clearly shows important findings. Next slide. The 2-year survival was equal between children and adults. It was about 95%, and 97% were of immune suppression at 1 year post-transplant. There were 5 deaths which were related to infection, and this occurred during the COVID pandemic. Next slide. The 2-year event-free survival was about 82%, but there was a big difference between adults and children. For adults, the event-free survival was about 95%, but for children, it was 68.4% because there were 8 graft failures in children, which we think it had to do with kids' bone marrow, because children are not like, or rather adults are not like big children, but there was absolutely no graft failure in adults. Next slide. So early data suggests that preconditioning with hydroxyurea, hypertransfusion, and thiotepa and post-transplant cytosol reduces the risk of graft failure in children. When we reanalyzed 26 of our cohorts who had upfront hydroxyurea with hypertransfusion, their outcome was similar to adults in terms of event-free survival. Next slide. But so far for children with strokes, this has been a successful strategy with no deaths. For haplobone marrow transplant with PTCY without TIPA and the conditioning. If you look at kids with age 11, some one age 8 and 8 who had moya and significant cerebral vasculopathy, most of these kids are now cured of this disease. Next slide. We've also found that there's improved hemodynamic changes in the brain in adults following transplant for sickle cell anemia, with improvement in oxygen extraction fraction, which goes up because of chronic anemia and cerebral blood flow, which gets better. Next slide. And this was something we recently published in Blood Advances, which clearly shows that if you look at the pre-haplo and post-haplo bone marrow columns, you can see hemoglobin improved from about 8 to 12.9. Hemoglobin S mirrors that of the donors, and the cerebral blood flow improved, including the oxygen extraction fraction and the cerebral metabolic rate of oxygen. Let's like, which are parameters that are distorted with chronic anemia. Next slide. And as you can see here, cerebral hydrodynamic, with the image to your left, A, that is the hyperemia you see with cerebral blood flow in the brain of a patient with sickle cell anemia. And the blue is the improvement post-transplant. Next slide. Kotlefitsu at the NIH has also shown reversal of precapillary pulmonary hypertension in a patient with sickle cell anemia who underwent haploidentical peripheral blood stem cell transplant, again validating this strategy. Next slide. So I would like to conclude that recent evidence shows that a reduced intensity haplo bone marrow transplant with pre-transplant ATG post-transplant cyclophosphamide with either 400 centigrade of TBI or the addition of thiotepa allows virtually all sickle cell disease patients, except those with severe heart, lung, and kidney disease, to receive curative transplant. The risk of graft-versus-host disease, graft failure, and serious severe graft-versus-host disease are all less than 10%. It provides an acceptable toxicity profile, results in full donor chimerism, mitigating the high risk of myeloid neoplasm, and early data suggests engraftment in children can be optimized with preconditioning. The extensive graft manipulation technology in gene therapy pits itself against the relatively inexpensive drug-induced immunologic tolerance used in T-cell replete-based approach with post-transplant cyclophosphamide. And I'll leave by saying that all sickle cell disease patients should be followed closely for late effects post-curative therapy. Next slide. Thank you.
Thank you very much, Dr. Kassim Adetola, for this great talk about the future. I think that many of the patients suffering from sickle cell disease in the low and middle income countries are just dreaming about the curative therapy. So one of my questions is about the indications for curative therapy for sickle cell patients, specifically for those who are living in low-income countries, where you know that majority of them are very poor.
So, yeah. So thanks, Dr. Tishilo. So that's a dilemma. And irrespective of what kind of chronic therapy you talk about, I mean, curative therapy you talk about, it's still expensive. However, if you look at it on a proportional scale, if you look at an allotransplant, most of the drugs currently used for allotransplant are probably available, even if it's in generic doses. I mean, if they're generic brands or biosimilars, they're now available, whether you get it from India, Brazil, or whatever. The second thing with a transplant is donors, right? For a long time, we were plagued with availability of donors because, you know, when you look for mass sibling donor, really, if you comb the family well, probably you get only 6 to 10% of patients with disease and having a sibling who also is disease-free and is a perfect match. But since advancement or improvement in transplant technology, where we've now been able to improve the outcomes with haploidentical transplant, virtually, unless you drop from out of space, everybody has a family member. You just have to find them. And if you can screen your family members, they usually, if you're nice to them, they'll provide the bone marrow for you for free. So that makes at least 90% of donors, based on the public studies we have, having available family donors. So if you extrapolate this to low-income countries, that would be an affordable strategy. I know the cost is relative, But if your family donors will be the donor for the new stem cells, and somehow the drugs can be available in available centers, that would be the lower bar to climb compared to other curative therapies.
Okay, thank you. I don't know if in the chat there are other questions, so I would like you to give more comments about the relative mortality in children that was higher than in adults when you presented your experience on the haploidentical stem cell transplant.
So the mortality wasn't higher in children. It was the graft failure rate.
Okay. Okay.
Yeah.
Oh, yes, I understand.
Yeah. So it was the graft failure rate. And what we suspect following haploidentical transplant is that there's a lot of immune turbulence when you do haploidentical transplant. And when we looked at mouse studies, preclinical studies, it was clear that if you look at the bone marrow vascularity in mice, it's pretty revved up. And based on that, when they subjected the mice to chronic transfusion, it improved bone marrow cellularity, and they were able to overcome the immunologic barrier. The other thing we've seen from thalassemia, which have had similar problem in younger children with thalassemia, is that they use upfront preconditioning. Some will use fludarabine and dexamethasone, like in the Indians group, and other people have used things like azathioprine as well as hydroxyurea and hypertransfusion, if you look at the London group. So all these are able to overcome that immunologic barrier we see in children. So we suspect, with the haplo for sickle cell disease, we ran into the same problem. And so the strategy, and of course, I showed the preliminary data where when we looked at the subset of patients who had severe disease and were on transfusion and hydroxyurea at the same time, and we compared them to the children who just came to transplant with nothing prior. Those children who were on transfusion for at least 2 to 3 months, as well as hydroxyurea, closely between 20, 30 milligrams per kilogram body weight, were able to have better engraftment. So I think moving forward, that's kind of the strategy we want to adopt, especially in people less than 18.
Thank you very much, Dr. Kassim.
Yeah.
Thank you very much. I need now to congratulate you and to ask Dr. Stoffman now to present his talk, because I know that he will move very earlier. Thank you
Yeah.
very much, Dr.
No,
Kassim.
thank you. I'll be on mute and about listening.
Okay.
All right. Perfect. Well, thank you very much. Yeah, I do unfortunately have to leave in about 20 minutes, so I appreciate shifting the order around. Welcome, everybody. I'm going to shift gears completely away from sickle cell into bleeding disorders. So I'm a pediatric hematologist in Winnipeg, Canada, and I was the medical director for our provincial bleeding disorders program for a long time. So I've had a chance to work with things. As we've already heard, 12 minutes is not a lot of time. So rather than diving deep into the data, I'm going to really give the 50,000 foot view of what sickle cell looks like, or sorry, what bleeding disorders looks like. Totally lost already. So I always want to start with how does a blood clot happen? Because I think it's important to think about what happens when you injure yourself. So, the first step is you have an injury to a blood vessel, the platelet plug starts to form. So platelets stick together, they aggregate around the wound. That's mediated by von Willebrand factor, which I always describe to families as the glue that holds the platelets together. Once those platelets are stuck together, they've plugged the hole, they have activation of the clotting system. So the hemostatic cascade activates within the plasma on the surface of the platelet plug. And then you move from the platelet plug to an organized clot. And then the body is very, very clever. And as all that is happening, it's starting to break down the clot. So the fibrinolytic system, which counterbalances it, starts to dissolve the clot. So you get a clot where and when you need it and nowhere else. And eventually that fibrin clot becomes the scaffolding for tissue healing. So a very clever system. Diving a little deeper into it, so primary hemostasis is that platelet plug, and I will get out my little laser pointer. So we have our injured vessel, we have exposure of subendothelial collagen that becomes the matrix where the von Willebrand factor initially attaches and bridges to the platelet through glycoprotein 1b. That activates the platelet, which then gets further aggregation with von Willebrand factor through the other glycoprotein 2b3a, and you start to gather this all together. So the torn vascular endothelium starts to catch the platelets start to catch each other, you end up with your primary hemostatic plug. Then you move on to secondary hemostasis. And I always say whenever I teach medical students and residents, I love throwing the cascade up. I love watching the reaction when they kind of have that brief gasp as they look at the cascade. I've always admired the cascade. I think it's a very elegant process that the body has this whole sequence of proteins that all work together. So there's a good pictogram. You know, we talk classically about the extrinsic pathway and the intrinsic pathway. Our newer understanding of things, the way I always like to describe it is more the activating pathway and the propagating pathway. So, you know, you've had your vessel injury. Here's the secondary side. You've got exposed tissue factor. Tissue factor activates your factor 7. Your factor 7 activates a little bit of factor 10, which activates a little bit of thrombin, gets you a little bit of fibrinogen to fibrin, and then the feedback loop really causes the explosion, which we now call the thrombin burst. So that feedback loop to the intrinsic pathway is what turns on your factor 9, and the factor 9 cofactored with factor 8 really drives the whole process. So, you know, this kind of answers the question when I started my training 20-something years ago, why does hemophilia matter? So if you don't have factor 8 or you don't have factor 9, but you have all these other things, why do you bleed? And now it's that understanding that if you don't have this whole system in balance, it all falls apart. And I will say as a trainee, what drew me to bleeding disorders was that you have this incredibly elegant system and you pull out one piece and it all falls apart. So I always thought that was really quite, it's a testament to the elegance of our hemostatic system. And here's my most simple picture I could ever show, which is the balance. So really, when we talk about all of those different factors and the whole hemostatic process, it's a balance between clotting where you want, when you want, as much as you want, and going too far and either you don't clot enough and then you have a bleeding problem, or you get overzealous and now you have a clotting problem. So when we think about hemostasis, that whole elegant pathway is about maintaining that perfect balance between pro and anticoagulant forces to keep us from bleeding or clotting, to maintain that homeostasis. So what I want to do is move into kind of a discussion of where treatment has gone as we talk about managing bleeding complications. So keeping in mind that balance, keeping in mind that intricate pathway, I don't have I'm not going to put slides with the deep dives, but really I want to start with how the pipelines have moved. So the original pipeline is classic treatment. So you put back what is missing. This started in the 60s with cryoprecipitate. We knew if we froze plasma and thawed it, factor 8 and fibrinogen would fall out of it, and we could use that. And you're missing factor 8, we put back the factor 8, it's better. Then we got progressively smarter, and we had, factor derivatives. So rather than just cryo, a little bit of everything, we would harvest plasma-derived factor 8. Then we got even better at that, and we went to recombinant factor 8, so we'd make it in a lab. It got progressively safer. Certainly we saw the HIV hepatitis C pandemic that decimated our hemophilia population in the 80s. But we got better and better at that. So classic treatment, we take it. You're missing a protein, we put it back. So we pulled out a piece of the puzzle, we put it back in, everything comes back together. Well, then we got really good at that part. But there were still challenges with that. It didn't last very long. It was a burden of treatment. The risk of inhibitors became a problem. There were still infectious complications in the plasma-derived products. So then we went into the new solutions. So still the same idea. Something's missing, we're going to stick it back in. But we found better ways to do this. So this is where we saw the advent of extended half-life products. So now we're taking our factor 8 and our molecule, which we've made in the lab, and now we're going to attach it to albumin, so it'll stick around a little longer. We're going to attach it to the Fc portion of immunoglobulin, so it'll get recycled. And now what we see is instead of needing to inject 3 times a week for good preventative care, we can inject twice a week or maybe once a week for the equivalence of it. We got better and better at these products. We have newer derivative molecules. So the latest, BIV001, looking at, it's got its new name and I can never remember what it is. But the new molecule where we have the von Willebrand sealing for factor VIII replacement. Well, let's design a molecule that uses von Willebrand to kind of drop it off where it needs to be. So we got better and better at doing the replacement therapy. And then people started to think, and this is, I borrowed this concept from a colleague of mine in the States many years ago, and I give Brian credit every time I talk about it, is instead of looking at replacing things, let's take a new approach and let's ask the question, is hemophilia really a deficiency or is it a defect in thrombin generation? Like what part of the pathway are we looking at? Yeah, pathophysiologically, hemophilia is a deficiency of the factor. Factor VIII is missing, factor IX is missing. But is that really the problem? Or is the problem that because of that deficiency, we now have a defect in thrombin generation? So, the scientists and the companies started to say, well, maybe we need to address this at a different level. And that's where we came into the non-replacement therapies. So now I get to put up another slightly scarier diagram. So this is the same diagram of the clotting cascade. So here's your intrinsic pathway, here's your extrinsic pathway, and now we're looking at that balance. So the classic, if you remember my little image of the scales, the classic picture was one scale wasn't full enough, so we would just add it to that side of the scale. Now we're looking at rebalancing the other way around. Instead of fixing the side of the scale that's tipped, we're tipping the other side of the scale. So instead of replacing things, we're looking at, well, what if we inhibit tissue factor pathway inhibitor? So tissue factor pathway inhibitor would normally put the brakes on clotting. Well, what if we block it? So now we've taken the brakes off of a clot. What if we block antithrombin? What if we look at completely different ways to do things? So, non-replacement therapy, emicizumab, kind of Hemlibra kind of falls in there, right? We're not replacing anything. We're replacing a function without replacing a molecule. But can we take the brakes off? Obviously, concerns here is we're tipping the balance, right? If we're now, instead of fixing bleeding problem, we're changing the anticoagulation side. Are we going to go too far? And certainly the early studies with some of the TFPI inhibitors did end up with thrombotic complications. So we have to be careful, right? As we try to rebalance, do we fix too far? Do we fall off the other side and create new problems? But definitely a new way of looking at it is saying, instead of saying we're going to fix what's missing, we're going to change, instead of replacing the piece that's missing, we're going to fix the process that's broken. And then, of course, can't talk about this without talking about gene therapy, which is coming. We talked about transplant with sickle cell. We're going to talk about gene therapy with sickle cell. Gene therapy has been a long promise. When I started in hemophilia care 25 years ago, there wasn't much movement in products because people kept saying, well, we got gene therapy. It's coming. We know the gene. We're going to fix it. It'll be fine. And then 10 years later, when they hadn't, the companies finally said, we need a better way to treat this because gene therapy obviously isn't tomorrow. But it is coming. So factor IX was originally the gene therapy option. Less patients affected. It's about a tenth the group that is hemophilia A, sorry. But it's a smaller gene. And the other thing with factor IX is you don't need as much, right? If we can get you a few percent of your factor IX, you'll have a clinical effect. Whereas for factor VIII, we think probably 12 to 15% is the sweet spot. Lots of studies are underway now with 8 and with 9. Challenges there. What vector do we use? How do we get the gene in? How do we get the gene in without causing damage? The AAV vector is the classic vector we've used. It's non-toxic. It goes to the liver to drop off the transgene. That's kind of helpful. It does cause some hepatitis in the studies we've seen. About a fifth of people already have antibodies to it. So what happens if we can't use it? Now there's studies looking at how do we overcome the vector antibody. With the original factor studies, looking at factor 9 padua, so a variant that's hyperactive. So if we're going to put a transgene in there, let's put in a super transgene as opposed to just the regular gene. So all these studies are, I don't have comments on the 8 studies, but those have kind of followed suit with the similar kind of approaches. Let's see if we can get a hyperactive variant. Let's see if we can get a vector that's going to work really well. Manufacturing is getting better, so we're getting more and more of the transgene in there. And what we're finding is patients who've been part of the trials, many of them are coming off prophylactic altogether, several years out. Lots of questions still about durability of response, efficacy of response, long-term complications that we don't know, insertional mutagenesis we don't think is an issue. These are replacement transgenes, but it's finally coming. And in the last minute I've got, we'll talk a little bit about new considerations. So as I kind of mentioned, when we looked at rebalancing therapies, at non-replacement therapies, are we going to tip the balance too far? Are we going to end up causing clot? So new approaches bring new challenges. So what about new inhibitors? Can we get inhibitors to things we didn't expect before? When we use non-replacement therapy, are we just pushing off factor VIII inhibitors until 2 or 3 decades later? How do we use them? What happens when you bleed? How do we deal with an acute bleed? As we think the developed world and the developing world, low and middle income countries and high income countries, who's going to supply them? Who's going to pay for them? When gene therapy was approved in the States, it was in the papers as the most expensive therapy ever approved in medicine. And then, as I've mentioned, what about the risk of thrombosis? So lots of things to think about. I don't have time to talk about thrombosis, which is kind of the other piece of it, but new therapy is coming on that side too. But really, it's exciting time for hemophilia, but with new change, with new opportunities, brings new things we have to think about. So with that, I will thank everybody, and I'm going to stop my sharing. Thank you very much. I'm sorry I'm going to have to leave in a few minutes, but yeah, thank you very much for your attention.
Thank you very much, Dr.
Yeah.
Jason, for this great talk. Very interesting. And as I told, for sickle cell disease, people are dreaming for a curative therapy for the next years. So I have just one question. How are the new treatment options changing the approach to bleeding disorder globally? And if you can have also the second sub question is now most of these blood disorders are in countries with low income. So my question is, what are implications for the developing world of this new treatment? Do you think that this new treatment will be affordable and accessible for the low and middle income countries? Over to you.
I mean, all great questions, which I've kind of touched on a little bit, is we really are thinking very differently now about how we treat bleeding disorders. And I will say in our clinical practice once we had Hemlibra available to us, we didn't think much about inhibitors. It was kind of, well, we'll treat you. If you get an inhibitor, it doesn't matter. We got Hemlibra. So it's in the developing world, I think, or sorry, developed worlds, the high income countries, I actually think we've probably gone from spoiled to more spoiled because we've always had really great options. I did a lot of outreach work with the Hemophilia Society of Delhi in India, and they were always impressed upon me how spoiled we were just to be able to we could treat lots. I think now we have to think differently about how we treat, and it's changed how we relate to patients because we can think very differently. They're more active than they ever were. So now we're this promise of a normal life is more and more real. How do we manage that? How do we deal with complications that we may not have known about? We know as we've gotten better at treating hemophilia, there's more older hemophilia patients who are having coronary artery disease because they didn't get atherosclerotic plaques when they were bleeding. In terms of lower middle income countries, I think the changes actually are the trickle down is a good thing. Part of it is that as we get to newer and newer therapies, which are a challenge for even high income countries to afford, those other therapies become more affordable because they need to market them. So they start looking at new markets. Low and middle income countries get access to therapies sooner because the companies are making them, they want to market them, they need that volume to distribute them. So that's a helpful thing. I remember when I was in India at the early days, discussion of landlines didn't take on in a lot of the communities because it was easier just to jump right to cell phones. So I think as we see where products are going, companies are going to look to those low and middle income countries. There's also the opportunities for study when we're looking at new drug trials, the population is there and they're hungry for therapy. It's opportunities for companies have a vested interest in getting in there, and that helps to promote and then continue those therapies. So I think it's promising for everybody. I think there is, all this development will impact everybody. I think it's how we get the access to them, how the approvals work, and making sure we keep the companies accountable to the global burden of hemophilia and not just the first world burden. So I hope that answers those questions. And I do apologize again. I have to leave. I'm sorry. I'm going to miss your talk, Dr.
Okay.
Chebby. So, all right. Thank you,
Thank you very
everybody.
much,
All
Dr.
right.
Jason, for your great talk. Thank you very much. Goodbye. Thank you. Thank you. Now let's move to the last speaker, Dr. Maureen Chebe. Welcome, please.
Thank you very much. I was trying to unmute, and I hope you can see my slides. Well, good
Yes.
day, everyone. My name is Maureen Chebe. I'm an adult hematologist at Brigham and Women's Hospital, associate professor at Harvard Medical School, and I run our comprehensive sickle cell center. I'd like to thank the organizers for inviting me to talk about gene therapy in sickle cell disease and thalassemia, specifically in transfusion-dependent thalassemia. I'm going to try to use my 12 minutes. Okay, great. As a brief background reminder, adult hemoglobin is made up of alpha and beta globin chains, and both sickle cell disease and beta thalassemia are beta globin disorders. Sickle cell disease is a monogenetic disorder. It's a qualitative beta globin disorder, as opposed to thalassemia, beta thalassemia, which may be caused by many different mutations, all causing a quantitative disorder in beta chains, specifically in transfusion-dependent thalassemia, where there are very few beta chains. So Dr. Adetola just gave us an excellent lecture on hematopoietic stem cell transplants in sickle cell disease, which requires a donor and has been of significant success in these disorders. Of course, it comes with some challenges, a limited donor pool, which although the donor pool has increased, but also the chance of immune incompatibility. Now, gene therapy takes the patient's own hematopoietic stem cells, modifies them ex vivo for now, and then uses them so that we are less limited, or rather not limited, by donor availability. Many of us are familiar with this graph that shows the level of expression of globin chains at various times in life. And if you're not familiar with this graph, I'd like you to just focus on the time of birth. And I'm just putting this up there to show that the beta globin chains that we're talking about really are increased after about 6 months of life. And prior to that, gamma globin is sufficient to perform the functions of beta globin. Depicted a different way, before we are born, our hemoglobin is made of alpha and gamma chains. So even patients who will subsequently show beta thalassemia or sickle cell disease are perfectly normal when they're making fetal hemoglobin. After birth, we then make beta globin, so that if you have sickle cell disease, it then manifests, and the same is true of beta thalassemia. Now, BCL11A is a major repressor of this switch from gamma globin to beta globin. Thus, the inhibition of BCL11A increases fetal hemoglobin and has been a primary target in many gene therapy strategies, where the idea is to make the individual produce either gamma globin or fetal hemoglobin or something that resembles fetal hemoglobin in some fashion. So gene therapy for sickle cell disease and transfusion-dependent thalassemia is targeting this defective beta globin gene, where gene therapy either adds new copies of a gene to replace the defective beta globin gene, or aims to block the switching of that beta globin, of gamma globin gene to beta globin gene, so that the patient then makes gamma globin and makes fetal hemoglobin. Here is one artistic depiction of the idea of genome editing. The idea is to use these molecular tools that we now have to erase specific sequences within the genome and to replace them with something with sequences that we would prefer. Gene therapy approaches in beta globin disorders vary from gene addition to gene correction to gene silencing. So currently there are 3 gene therapies that are available for sickle cell disease and transfusion-dependent thalassemia, which I'm going to subsequently call TDT. Casgevy is indicated for both disorders, and it uses a mechanism of gene silencing using CRISPR-Cas to inhibit BCL11A and induce fetal hemoglobin production. Lyfgenia and Zynteglo are approved for sickle cell disease and TDT respectively. And these use a lentiviral vector, sort of like an envelope that carries a modified beta globin that's modified so that it resembles fetal hemoglobin in function, where the product is an increased level of hemoglobin, this modified hemoglobin A in both products. It's approved for patients that are greater than 12 years of age, and these are the countries in which they are approved. For the individual patient, the patient generally gets red cell transfusions for at least 2 to 3 months before mobilization of his or her stem cells, which takes about a week, though it may need to be repeated. These stem cells are then shipped off to a central lab for gene modification, and there are mandatory safety tests that make this process about 6 months long. So the patient is waiting, not in the hospital, obviously, at home for this time. Once the product is ready, the patient undergoes myeloablative conditioning with chemotherapy and then infusion of the gene product, with an expected hospitalization of about 4 to 6 weeks as far as everything goes smoothly, and then with really close follow-up as an outpatient for about 1 year after therapy, after which the follow-up may be less frequent. The approval indications are pretty broad. So for Casgevy, for instance, is approved for treatment of patients that are 12 years of age or older, that have recurrent vaso-occlusive crisis in the case of sickle cell disease, or are transfusion dependent in the case of thalassemia. Lyfgenia and Zynteglo are pretty similar, except that Zynteglo may be approved in patients as young as 5 years of age. So what are the advantages of gene therapy? It's a potential cure for these disorders, reduced symptoms, less need for transfusions, long-term impacts medically and emotionally, which we hope are positive, and less restriction of activities for individuals. It is personalized medicine and should improve the quality of life for patients. But then what could the challenges be? Our challenges, things that we're grappling with at this time are which gene modification method is superior? Now that there's gene therapy and there's bone marrow transplant, both which are curative, which should we recommend in a particular patient? Both require conditioning toxicity, conditioning medication that has toxicity. Maybe the long-term impacts are not positive. Maybe they're negative. Now we have delivery of ex vivo products, where the goal is really in vivo delivery of products. Manufacturing costs are exorbitant, and we need to think about equitable distribution. The vast majority of patients, as you know, reside outside high-income countries. So what do we do about this? As it stands, there are barriers to current therapies: insufficient blood transfusion support, iron chelation, hydroxyurea. And there are infrastructure challenges that compound the barriers that we see even within the US. So I think these challenges are greatly outweighed by the opportunity of improving outcomes. You know, due to the unique accessibility of the blood and blood system, we can expect to deeply understand the impact of these therapies as we deploy them, both at the molecular, cellular, and physiological level in patients. You know, we have a significant, there's a potential for a significant impact on clinical need for the 300,000 or more sickle cell patients, 25,000 TDT patients that are born a year. You know, none of these advanced therapies will easily scale to match this problem, but this doesn't suggest that they are insurmountable. It will take diligent planning, coordination by us, by all stakeholders, to make these available in places of the world where they are needed the most. Thank you.
Thank you very much, Dr. Maureen Achebe, for this very interesting talk on gene therapy. So your last slide displays the burden of this disease, specifically in sub-Saharan African countries. So what do you think, how do you suppose that we can ensure that gene therapy will be available in low and middle income countries, specifically in those two countries that you showed in your last slide, Nigeria and DRC? They are the biggest countries with the higher prevalence of sickle cell disease. How do you think that in the next years, gene therapy will be available?
Yeah, thank you. Of course, this is sort of an obvious question that everybody is sort of grappling with. I think, you know, as the previous speakers alluded to, gene therapy is expensive. In the US, outside the US, anywhere, it's expensive. And even in the US, we're advocating for governments to take some responsibility in the cost of these therapies. In low and middle resource countries, we need infrastructure, we need advocacy, we need increased training of providers to provide these therapies. I mean, these are obstacles that we are trying to work on for even existing therapies. I think anywhere we'll be able to get bone marrow transplants to, we'll be able to get gene therapy to. Gene therapy is probably more expensive, but at least we'll know that it's a financial problem. Right now, our problems with getting these therapies to low and middle income countries are sort of broader. They may all be, I mean, they are all influenced by finance, but our problems right now are actually broader than that. So I think it will require advocacy, it would require funding, and we would hope that our governments will see it important to invest in these advanced therapies and other therapies for hemoglobinopathies, since we shoulder the burden of these diseases in the world. In sub-Saharan Africa, it will require increasing awareness of patients, of families, of the public, to the importance of addressing these disorders. I think it feels like an insurmountable problem, but I think if we take them one by one, we should be able to push for these therapies to get, and as we gain more confidence in their long-term success, that we should be able to get these therapies to places that need them.
Yes. So as you said that we need to move step by step. So taking in consideration the present situation in most of the sub-Saharan African countries, do you think that it would be interesting to plan multicentric or regional centers where all the African countries can plan to realize, for example, the bone marrow transplant, and after some years, they will be able to introduce the gene therapy. What is your feeling?
I think that's a wonderful idea. You are, of course, you are one of the superior minds in sub-Saharan Africa as regards to sickle cell disease. I think that is not only a good suggestion, but is probably one of the only ways or strategies for this to be realized in short order. I think even in the U.S., right, where gene therapy is being performed in specific centers, right, in not all centers, and then the manufacturing of the product is actually sent in a central location. So yes, for sub-Saharan Africa, it would be great to have designated centers where the infrastructure can be developed to have, and then patients can come to those centers rather than, so we'll sort of pool resources to make that happen, rather than planning to have multiple centers, which will likely take us longer to get to a place where people can routinely get care.
Thank you very much. Okay, thank you very much, Dr. Maureen Achebe, for this great talk. I think that the participants, they have a doodle in the webinar. They are asked to complete and to respond. There's a question in the QR. Yes, in which countries is gene therapy approved?
You mean
Dr. Maureen?
Okay, so Casgevy, Lyfgenia and Zynteglo are only approved in the United States. And then I think I had a slide with the list of countries for which Casgevy is approved. It includes the United States, the EU, Switzerland, Bahrain, I think the UAE, and I may be missing one country. Maybe missing one country, but that is, I think those are the countries I can.
And I think that India is planning to realize gene therapy in the next years, as the government decided to eradicate sickle cell disease, to reduce at least the burden of sickle cell disease in India.
So I missed Canada and Saudi Arabia.
Okay.
So the US, Canada, UK, the EU, Saudi Arabia, Bahrain, and Switzerland.
And there's no African countries that are able now to be involved in gene therapy.
At least not, at least not that the companies have any agreements with.
Okay, I see. Yeah. Okay, thank you very much. I'll give back the microphone to the organizers. I think it was a very good talk and very interesting webinar. Thank you very much again, Dr. Maureen Achebe.
Thank you, Dr. Shalolo.
Over to the technical assistance.
Thank you, everyone. So next up is a short break. So please join us afterwards for 2 exciting sessions that are starting at 11:55 a.m. EST. If you would like, I see there's still some questions in the chat. We can send those over to the panelists and then they can get back to you on those questions. Thank you very much, everyone. We'll see you shortly.
Thank you very much. Goodbye.
Thank you.